the slides along with you. So some of these slides are second view for some of you who have heard my talk on diabetes and COVID before, but I have added, the second half is a huge amount of new slides and one that I just found last night, some information as I was putting this together. So it is important here for us to get a little quick review of the course of the disease of COVID. There is basically described as 3 different phases of the disease. First phase, where it's out in the community and you are living in that environment. Then you get infected, exposed. From the time of infection to the time that symptoms come on is someplace around 5 days, plus or minus. So this is the asymptomatic period. This is a time when you do not have symptoms, but you've got the virus. Virus is, oh, I keep hitting that button. Virus is replicating, and you have the chance to be sharing it with others. This piece is the important one to understand for some of the things that we're going to be talking about. So this would be here where you do the prevention phase. You don't have any symptoms and you don't want to get sick. So what things can you do during that phase are some of the things we will talk about. Then symptoms kick in, and what we have come to learn is that the manifestation and the symptoms of COVID vary from individual to individual. But whatever those symptoms are, they kick in someplace around 5 days after exposure. And if you are the unfortunate individual who ends up in the hospital, that typically will be a week plus or minus after the initiation of symptoms, when things begin to not do well. And that's where I call early treatment. You've gotten the symptoms, you've been tested, you've got a positive result. What can you do? And then in third phase is when you get in the hospital. And what we have known is that majority of the patients, and these were early numbers, these numbers are much different now. The individuals being hospitalized are way less. This was last year's data, so I probably should have taken that slide out. The immune system is something that we need to know about as to how this is going to be tweaked, if you may, for you to do well with COVID. So there are 2 phases to the immune system. One is called the innate immune system, that which you were born with. So the baby has an innate immune system that is working. And babies have a very good innate immune system. So there are certain cells that are aligned with it, which we'll see in the next slide. And then there is the adaptive immune system, which, as the term implies, it begins to adapt, begins to change, depending as to what you are exposed to, okay? So a few names here of cells that you might have heard about. On the innate immune system, you have the neutrophils, the macrophages, natural antibodies, which are less specific. The natural killer cells, which you're going to see in some slides up ahead, are all part of the innate immune system. The adaptive immune system is now got a certain particular type of lymphocytes, the B lymphocytes, the T helper lymphocytes, cytotoxic T lymphocytes, and these will develop antibodies that are the targeted missiles, okay, that will hit a specific part of bacteria, virus, whatever foreign agent is coming in, okay? So one of the important things here for us to understand out of COVID-2 or COVID-19, SARS-CoV-2, is things that we learned from the previous infections, the MERS and the CoV-1, the SARS of 2002. What we have learned from this is that basically when the infection hits and you are infected with it, the asymptomatic period, during that time, the virus shuts down essentially or diminishes the function of the innate immune system. The innate immune system is, again, the first line of defense, okay? The other thing here to mention on the immune system is that that innate immune system are the ones that is very strong in babies. As we age, it is not as strong, okay? So here you get the virus, and it has got mechanisms that it shuts down the surveillance system, your defense system. What does that do? It allows the virus now to replicate uncontrolled. That is why during those 5 days, you feel fine, but that virus is replicating at an incredible rate. By day 5, the immune system kind of wakes up and says, what happened? And by that time, the virus is just like everywhere, and you have all different sorts of symptoms. So understanding that, one of the things that we want to do is learn what can we do to strengthen that innate immune system. Instead of it being shut down or slowed down initially, what can you and I do to keep that innate immune system functioning at excellence, okay? The other thing here to just mention, and this was from last year also, what we know is that there are a very large number of individuals who have been exposed to the virus and actually have antibodies, but they have not come around and been tested as a positive COVID patient. They did this in samples across the US, and here's just some data from New York. And what they were able to see here from blood samples versus the actual number of cases that were reported at that time. There were 10 times more positive antibodies individuals than cases. So our cases in the US are, I didn't look up the numbers here, but let's just bring up the number of 3 million. Easily, it's 10 times that, the number of people who have been exposed and have antibodies. Okay, question. The antibodies are now part of the adaptive immune system. They have seen the virus. It has developed antibodies specific to that virus. Yes. Correct. Yes. So unlikely, again by biology 101, okay, it is unlikely that they will get infected from it, okay. All right, so with that kind of framework and background. What can we do here for prevention and early treatment? So if you go to the CDC website, here's what they say if you're caring for someone sick at home. You can type this in yourself and find it. If you're caring for someone with COVID-19 at home or in a non-healthcare setting, follow this advice to protect you and others. Learn what to do when someone has symptoms of COVID-19 or when someone has been diagnosed with the virus. This information also should be followed when caring for people who have tested positive but are not showing symptoms. And then it goes to, you scroll down a little bit, and I say you provide support, help cover basic needs, help the person who is sick follow their doctor's instructions for care and medicine. For most people, symptoms last a few days. People usually feel better after a week. See if over-the-counter medicines for fever help the person feel better. Make sure the person drinks lots of fluids and rest. Help them grocery shopping, fill in prescriptions, whatnot. Take care of their pet. Limit contact between person who is sick and their pets when possible. And watch for warning signs so if they get really sick. So that's what the CDC says to do if you're caring for someone who's sick. And here is the handout that the CDC has here for 10 things you can do to manage your COVID-19 symptoms at home. Number 1, stay home. Number 2, monitor your symptoms. Number 3, get rest and stay hydrated. Number 4, call the healthcare provider ahead of time and tell them that if you're going to show up. If you have a medical emergency, call 911 and tell the dispatcher that you've got COVID. Cover your cough and sneezes. Wash your hands often. Stay in a specific room away from others as possible. Avoid sharing personal items. Clean all surfaces. So I look at that and I say, there's got to be more, right? What do they tell you to do? Stay at home, wait until you get sick. And when you get really sick, show up in the hospital and then let the hospital figure out what to do. I can't tell you how many times I have seen this play out from patient to patient to patient. They come to me, they tested positive. 5 days later, they're calling the clinic. What did they tell you to do? Nothing. Next patient. My doctor told me to just go home and wait. And I had one person tell me, I'm 80-some years old. My doctor basically said, go home and wait till you die. And it's like, there's got to be something more. That's not good advice. Yet the CDC doesn't do a whole lot better, unfortunately. So, ladies, how many of you have made bread, homemade bread? Okay, a few hands. Lorena does the bread making at home. You got to have flour, right, of some sort. You have to have water, yeast. You're going to throw in some other ingredients, right? And for you to come out on the other side with bread, usually those ingredients need to be mixed in a particular sequence. The baking needs to happen at a particular temperature. It's not at whatever temperature. There needs to be a duration for that dough to be in the oven. Right, there's a sequence, okay? Now, will you get bread if you pull one of those ingredients out? Or if you just use one of them? If all you have is flour and say, I want bread, will you get bread? If you have the yeast and you say, I want bread, will you get bread? Not too likely, right? So, I want to suggest that this is a disease that you have to do more than just one thing or one medicine, but that you have to do a multitude of things to end up with a good result, okay? And they might even need to be in a particular order and sequence so that you get the right result, okay? I'm not sure what that sequence is, but we are getting data and more data on this. But this is important here for you to understand. I want you to understand that this is not and a lot of the studies will say, we tried this particular medicine, it did not work. Well, maybe because what needed to happen is that you needed more than just flour. You needed to add some other ingredients to get the desired recipe. Follow? So I'm going to start off here with a whole bunch of stuff that has no medicines. This is all what we call lifestyle, something that all of you have heard me talk about before, okay? And it is important here for us to reiterate these, because this is the foundation. If these things are not working well, if you are breaking all these rules, okay, doesn't matter how many drugs and medicines we give you, we've got a weak foundation, the building is going to fall apart, okay? So let's start with sleep. Ideal amount of sleep, 7.5 to 8 hours, 8.5 hours per night. That's for adults. Children need more, and depending as to what age, as to how many more hours of sleep they need a night. And the ideal bedtime is between 9:30 and 10:30 at night. We've gone through that data before in the diabetes seminars in this setting here. Let me just remind you of a few things. Adequate sleep allows changes in the hormone levels that allow better binding of, remember I showed you those killer cells and the ability to destroy cells infected with these particular viruses. So good sleep improves the T killer cells, which is in that part, that first part of the immune system, the innate immune system. You get lousy sleep, those cells are not working optimally. The other important piece here is slow wave sleep is important here for growth hormone and affects the immune function. And that slow wave sleep typically is happening between 10 p.m. and 1 a.m. That slow wave sleep is important here, and just tagging it here to diabetes, even though this is not a diabetes seminar, but it also involves other hormones, okay? That slow wave sleep is healthy, is necessary for the immune function, for the endocrine function, for the glands, for the hormones to be working the way they're supposed to. And the less sleep you have, you're going to thus have decreased immunity. There's a whole article on that. We reviewed this study before where they took individuals, healthy individuals who had not been vaccinated. They had one group sleep deprived, and the other group sleep their normal 8 hours, that they were young, healthy, sleeping good, had not been vaccinated for several years. And at day 4, both the normal sleep guys and the sleep-deprived individuals get vaccines. And then they measure antibody levels 10 days out. And they got the influenza vaccine, measured antibodies titers after 10 days. in the sleep-deprived group was less than half than the control group. That means you're sleep-deprived, even though you get the vaccine for the flu, the body's not producing the amount of antibodies of defense for you than if you were sleeping well. Same idea here with susceptibility to common cold when you are sleep deprived, and it is not a huge amount, but less than 7 hours. Those who slept less than 7 hours had 3 times more likely of getting a cold than those who slept greater than 8 hours in the group that was exposed here to the common cold virus, the rhinovirus. And so enough on sleep. We talk about water. And under there I have the contrast shower concept as a method of giving you a fever, okay? And some will call this a fever bath, if you may. But what are the benefits of raising the body temperature? And in this group, they immersed them in a hot water bath, increased their body temperature, and this fever basically activated the monocytes. Again, that is part of the innate immune system is working extra fast, better with the body getting that body temperature. What about cold? And they looked at cold exposure together with pre-treatment, whether you heated them, and they found that you heat the body up and then you expose them to cold temperatures, or it induced leukocytosis, is basically an increased number of white cells and an increase another type of white cells. So that contrast of we raise your body temperature and then we bring you here to a cold environment, that is going to stimulate the production of white cells and of circulation of those white cells through the body. And they do this also in Finnish saunas, increasing the white blood cell count, especially if you are already in good shape. They tell me that it is common in Finland, where they will be in these really hot saunas for a long time, and then they go out and they just roll in the snow, okay? Talk about contrast, okay? And that being actually, you would think these individuals would get a heart attack, right? With that contrast. On the contrary, that it just stimulates the system and stimulates the circulation. They do quite well. Cytokine storm is something that happens. The COVID patient who ends up having respiratory issues and has to go to the hospital and has to end up on a ventilator, it is because there has been what we call that cytokine storm. The immune system has just gone crazy and all kinds of stuff is being secreted, and that is what is causing that lung to get filled with fluid. Well, interestingly, fever controls that. You don't get that terrible cytokine storm. I'll reserve the story here for a couple of more slides. The incidence of common colds cut by nearly in half in those who were using a regular sauna, sauna on a regular basis. And both the fever and the cold temperature being beneficial to the immune system. And again, different articles that basically give that conclusion. So you guys have, I think, most of you have heard me talk about this. If you haven't, if you have, this is a review. How do we do this? And how do I do this? And I am still doing this as of March of 2020. I've been doing this every night with the exception of probably 2 nights. I've modified it at times, made it a little shorter, but I continue to do this, and it is under the hot shower for about 4 to 5 minutes. You are raising the body temperature. You're not to scald yourself. You're not to burn yourself. Okay, it's just nice and toasty, and you feel yourself saying, "Ooh, that's nice and warm." Then the tough part follows, where you now have 30 to 60 seconds of cold water. How cold? As cold as you can tolerate, okay? And interestingly, our shower head kind of varies. Some days we get super cold, and some days we don't get it as cold. I'm happy for those days when it's not that cold. I think it has to do with our water heater having some issues. But that cold water, and it is perfectly okay to scream and shout in there. Okay, your singing time, do the soprano parts. Then you go to hot water again for a minute. Let that body temperature come back up. You have another 30 seconds of cold water. Go a third time, 1 minute hot, and a third cold water sequence, and you finish with cold. There are several patients that I have spoken with that I've been, I call them, how are you doing? Doc, I'm still having a little trouble breathing. And so I've kind of sequentially added stuff. This one is a little, and especially initially when we were all kind of learning what to do. I didn't want to scare them off with this right off the get-go, okay? So I did some other treatments, and a few days later I called him up, he's still having shortness of breath. Okay, time for you to do this contrast shower. And I've done this with several, and they say this is the best thing that has helped them with their breathing. Crazy as it may sound, okay? But this does something here to the airways. Remember I showed that slide here of that cytokine storm being dampened by fever. What does that cold do? You're raising the body temperature, and that cold water basically is closing the pores and what they describe as trapping the heat inside. So you have, for a longer period of time, this fever, if you may, that you created out of that hot water shower, okay? And that fever, bugs do not like heat. I was sharing here with you about cancer cells don't like heat, okay? So, but bugs don't like heat. So you are basically letting the body do some of the cleanup job with this, okay? I won't have a whole lot of data on this one, just make a statement, avoid sugar. Sugar weakens the immune system, and I liken it here to soldiers who go out to war, and before they go out to war, they get drunk. They're not gonna aim very well, okay? So sugar basically weakens the immune system, has the little soldiers there drunk and not aiming well or functioning appropriately. Fruits and veggies. I put here, and there'll be some slides to explain why, minimum of 5 servings per day. And I say, another way of thinking it, 2 cups of vegetables minimum, preferably raw, okay? And 2 or more fruits every day. Here's some data. And this study that they did of 83 healthy volunteers, randomized trial, and they tested them here after 12 weeks of being on this with some vaccinations. Those individuals who had the higher amounts of fruit and vegetable intake had almost twice the antibody production than those who had the low fruit and veg intake. Again, antibodies are part of your defense that you are now creating. That is now the adaptive immune system that you are creating with that. So you got to sleep well, contrast showers, avoid sugar, lots of fruits and veggies. The more fruits and veggies, the better the body's going to be at developing antibodies. And this is let me go back. Inhibition of SARS coronavirus infection in vitro by this compound, which this you can understand, a nitric oxide donor compound. What is nitric oxide? It's a particular compound that the body is producing. It has to do a lot also with how the blood vessels expand, contract. It's a nitric oxide reaction. And so they looked at the effect of fruit and veggie consumption on the immune function in older people. And again, a randomized trial. And yet another one, nitric oxide inhibits the replication of SARS coronavirus. So nitric oxide stops the replication of the virus. Nitric oxide is involved here with blood vessel endothelial function. Where do we find nitric oxide? And that's basically the abstract to say that inhibits this nitric oxide inhibits the replication cycle. And that's verbatim, their abstract of that article. So where can you find nitric oxide? And nitrates, nitrites in health and disease. Fruits and veggies. Pretty simple, especially the dark green vegetables. That's where you're going to find your best source of nitric oxide. So, nitric oxide, we know, helps stop the replication of the coronavirus. You get exposed to somebody, you are doing preventive care, you're doing early treatment care of it. As you got the virus, you want to stop it from replicating further. Why don't we tell patients, well, why doesn't the public health department have a little sheet? You got a positive test, here's the things that you can do. I shared this with the church a few weeks ago, something that I learned about 2 months ago or 3 months ago. You guys can go on YouTube and punch in there Dr. Brooke Goldner, and she's got several interviews there on YouTube. She's got a website as well. And the concept here being you get a green smoothie, and she uses it here to take care of autoimmune disease, but it also has been helpful here for diabetes, for heart disease, et cetera, et cetera. And her concept has been, it's hard for you to eat the amount of greens that you need here to reverse, in her case it was lupus, or reverse other autoimmune diseases such as scleroderma, and there's a whole host of different autoimmune diseases. So she and her husband, which is another nut guy, or health nut guy, I meant to say, they came up with this mixture. You start off, you got to have a good blender. You guys have seen Lorena, my wife, bring here the Vitamix to the cooking classes. So it's got to be a very good blender that can handle this. You're gonna get the big container of the blender, 3/4 of it, you're going to pack it with raw greens. By pack it, it's not just lightly put in there. You literally pack it in there, okay? Get a 1/2 cup of flaxseed. Put that in. You fill that 3/4 container Vitamix with water to that level. Then you have the top 25% or the top quarter part of the blender empty still, right? That part, you fill it with fruit, preferably frozen fruit of your choice. The sweeter, the better, okay? If you got super ripe bananas, those brown bananas that nobody likes to eat, those are the sweetest ones. Just put them in there too. The fruit, as she says, that's the sugar, okay, to let the medicine go through. The medicine is the greens, okay? There's a sweetener, and you just blend the stuff in our Vitamix. Takes about 1.5 minutes, 2 minutes. You don't know that there's flaxseed in there, just pulverizes everything. The Vitamix is so good at it. And you get this green smoothie that you look at it and we say, ugh, right? But it tastes great because it's got all that fruit. 1/4 of it is fruit, a fruit that of your liking, and whatever mixture you can come up with. So it actually tastes like fruit. That's green color because you loaded it with greens. So this is something that we have been doing, not that we have diabetes or that we have lupus or that we have any of these diseases, but we don't want to get sick. So, and I'll just say, I had COVID after explaining this here to the church members. I had my exposure and encounter and experience, and that's some of the stuff I was making myself drink. I wasn't too hungry during those days I was sick, but it is loaded with nutrients. So how much of this to drink? I think most of you are not diabetics. Actually, you're the one that told my wife about this, now that I remember this, okay?
I've been drinking her smoothies for maybe 5 months because of arthritis. I read her book, Goodbye Autoimmune Disease, and it's a 1-to-1 correlation. If I drink 4 16-ounce glasses, which is a lot, and I don't usually drink that much because it's too much for me to drink, I have absolutely no arthritis the next day. And it goes down. If I drink 3 glasses, a little bit. 2 glasses is what I usually drink, 2 16-ounce glasses. And the arthritis is there, but it's tolerable. If I get cocky and think, oh, I don't need that anymore, it's right back. It reminds me immediately.
So, yeah, I was going to say, now that I saw you, April, I said, April's the one that shared that with my wife at some point, and we checked it out and have been doing it ourselves too. All right, forest bathing, a little new concept there for fresh air. And here's some fascinating studies that they've done. Forest bathing, that's actually the title they put in the article, enhances human natural killer activity and expression of anti-cancer proteins. And they took 12 individuals. They spent 3 days in a forest. These were employees in big companies in Tokyo. You can imagine Tokyo not being a low-stress place. So they take them out into the forest. They walked 2.5 kilometers for 2 hours on the first day, and similar done twice on day 2. Measured the blood each day. They looked at white cells, T killer, certain enzymes, and basically what they found is that these things all go up each day. For 3 days, they have their baseline. Day 2, day 3, it's going up because they're walking in the forest, and they have found these compounds produced by certain trees out there, these phytoncides that are beneficial. So one of the things that they decided to do is, so come back here. Is it the exercise or is it the air? So they did the test in another study with the same exercise, 2.5 hours, 2 days, but they're the one in the city did not have that effect. So it's not the exercise that is giving this beneficial effect. It's the forest compounds. So they took it a little step further and went the wrong way. They actually, I put the other slide up. They actually then took medical students who are in the city and they used these compounds and put it as a diffuser in their hotel room, because they actually put them in a hotel room for this study. So the medical students who are getting exposed to this compound through diffuser had similar effects of improving their immune function, not to the same extent as when you were out in the forest, but these guys are, number one, med students. They're still in the city. They're still doing their studies. They're still stressed out by all their other stuff too. So fascinating that there's these compounds. When you walk out through Panther Creek, how do you feel? Great. There's something in the air, right? All those trees are secreting, and especially certain pine trees, compounds that are healthy for you. So that fresh air being helpful for you. The next one is exercise. And I won't spend a whole lot of time except to say that there's lots of studies, and this is just one of the reviews, compelling link between physical activity and the body's defense system. That as you exercise and when you exercise, you are improving your immune system also. All right, now we get here to the supplements or medicines. They said what we talked about is foundational. You've got to be doing that. It's easy for folks to say, hey, just give me the pill, and we forget the rest, okay? I cannot emphasize enough that the things that we just talked about are more important, okay, than these supplements, okay? But the supplements and medicines have its place, and so we're going to go over a few of them. Some of these you have seen. Vitamin D, 2,000 to 5,000 units every day. Where does that data come from? We have lots of data showing that vitamin D improves the immune function, helping here for whether you get colds or not get colds. It impacts both the innate and the adaptive immune system. We know that most of the United States is vitamin D deficient. All our time indoors, all the sunscreen lotion we wear, and so on, does not allow us to have the adequate vitamin D levels. The more fat cells we have in our system, the lower our vitamin D levels are going to be. Fat accumulates vitamin D and doesn't let it circulate. So, again, that's a Harvard study. Then here comes this other one, vitamin D supplementation to prevent acute respiratory tract infections. Positive effects there. They did a meta-analysis of 25 studies, 11,000 plus patients. Vitamin D helps the body fight acute respiratory infections, and it's best if you're taking it on a daily or a weekly basis, on a regular basis, to getting that supplement in you, okay? Then last year, there was this study, the TILDA study out of Ireland, showing that vitamin D supplementation could reduce the incidence of chest infections by up to 50% in some people. What we learned fairly on also is that, especially in the early wave of COVID, most of the people who were dying from COVID in the hospital had low levels of vitamin D. Those individuals with higher vitamin D levels fared better than those who had low vitamin D levels. Evidence that vitamin D supplementation could reduce the risk of influenza and COVID-19 infections and deaths. There's another article. Vitamin C. Yeah, so you're talking to an internist who doesn't know a whole lot about kids. Okay, so I don't have a good answer except kids. One of the things they did tell me, children are not small adults. You have to kind of treat them a little differently. So I don't have a really good answer as to what you do with kids. What I can say is the data is very strong that kids who get COVID are going to bounce back or have hardly any issues, minimal symptoms, and very little long-term complications compared to the adult stuff. Why? Again, the innate immune system is much more powerful in young kids, and as we age, it weakens out. So that's why kids do better. Vitamin C, 1,000 milligrams a day or more for prevention and for treatment, early treatment. When I had COVID and when my patients are positive, that's 3 times a day. So 3,000 milligrams a day. And it's cheap, easy to get. If you want to eat this with oranges and grapefruit, all the better, okay? You get more than just vitamin C that way. Vitamin C can shorten the length of stay in the ICU. That's been known for a while. And question, can vitamin C prevent or treat COVID-19? And people who are deficient in vitamin C could be more at risk of SARS-CoV-2, developing severe vitamin C deficiency is associated with increased susceptibility to infections, a less robust immune response, poor wound healing, and increased risk for pneumonia. Research suggested that up to 7% of the US population may be deficient in vitamin C. Fruits and veggies are a good source of vitamin C. It's an antioxidant, important for the production of collagen. Carnitine plays a crucial role in the immune system. So there's lots of information on vitamin C and its benefits. We're still kind of gathering information as to how it's going to fare out. There are lots of hospitals who are doing IV vitamin C in their hospitalized patients as part of their ICU protocol. So something to keep in mind, easy to get, and certainly won't do any harm. Again, the idea is it just one, or is it all of these? Okay. Zinc, you probably have been hearing. Let me just mention this. So I think a lot of the doctors have been getting the idea and the concept of vitamin C, vitamin D, and zinc supplementation. They've gotten my experience as I see these patients through my clinic, they are underdosing them. So they give it for 3-5 days, Vitamin C, vitamin D is like 400 international units. That, I mean, you just not enough. Vitamin C is 250 milligrams a day for just 5 days. Zinc, they're doing 50 milligrams. They've hit that okay, and they do that for 5 days, and it's just not enough duration here. If you've have been exposed to it, if you're COVID positive, or if you were in the hospital and get discharged, you should stay on these supplements. I tell patients at least a month. Okay, at least a month. And so zinc, 30 to 50 milligrams a day. And there's data here from the original SARS-CoV-1 of 2002 that zinc inhibited the replication of coronavirus, basically gets into the cell and shuts down the replication system of COVID. So that's the summary of that one. The zinc ionophore activity of quercetin. So the zinc needs to get inside the cell. So you take the zinc and it needs to find its way into the cell. So it can diffuse in there. You're going to get lower levels of it. But ideally, there are what they call these ionophores, these basically channels that open up in the cell, allowing zinc to go from outside the cell to inside the cell. And one of those agents that causes those pores to open is quercetin. You can find that in vegetables and fruits also. And it is just a whole lot easier for folks also to measure, you know, how much of this do you have? So just get a supplement at the health food store for quercetin for that. And I usually tell people 250 to 500 milligrams twice a day of that while you're sick or you tested positive. Okay. NAC, NAC. There's this article, an old article that I was not aware of, 1997, where people were given NAC treatment for 6 months. This is in Europe. And another group was given placebo. The group who got NAC on a regular basis had up to a 75% decrease incidence of influenza than those who took the placebo. And I was not aware of this study. This actually was a randomized trial back then. So we know it works for influenza. And so just recently, this article I have on my desk, N-acetyl cysteine to combat COVID-19, an evidence review, basically showing that it certainly seems very promising also, as best as they are seen from the different studies, that a NAC is also an agent that will help stop or combat or slow down COVID-19, to the point that FDA has vented the idea or considered the idea of making NAC a prescription item where doctors have to prescribe it so that they can have basically control as to the distribution of this. So health food stores were having a hard time getting their hands on a supply for it for a long period of time. The 2 health food stores that I frequent did not have it. I haven't gone there recently. We got When I saw that happening, I'll just be honest with you, I went online and found my source online and ordered a bunch, and we have it in our stockpile for the time needed, if needed. Okay, but it's something else here to consider. Ivermectin. Ivermectin has created a lot of discussion amongst folks. I'll tell you my story on ivermectin. My oldest boy had COVID back in January of this year. And as I shared at a seminar, I was quarantined. I got in his room. I was in his face, all of us in the house. And none of us got sick. And my antibodies were negative. And I said, how in the world did that happen? That's the innate immune system just working really hard with that variant that was circulating at the time. He got ivermectin, so we got extra supply of ivermectin and had on hand at home. So when I got sick, I had my ivermectin, which I began to take, and I called in a prescription for my wife. She was not able to pick up the prescription because the pharmacist said, well, it doesn't work. We don't have it. I can't give it to you for COVID. The daughter of our office manager had COVID at the same time. I called her a prescription up to Kingsport. Same story. Pharmacy did not fill it. The pharmacy was overriding my prescription calling. So what's the deal with ivermectin? It's been highly politicized. I'll just give you a few studies that I have found. Use of ivermectin is associated with lower mortality in hospitalized patients with coronavirus disease 2019. It's published in Chest. It is not the Enquirer. It is not Housekeeping Magazine. Okay. This is published beginning of this year. 5-day course of ivermectin for the treatment of COVID-19 may reduce the duration of illness. It's a randomized controlled trial. We talk about gold standard for studies are randomized controlled trials. Here we have a randomized controlled trial for ivermectin, 3 days shorter duration in hospitalized patients. Ivermectin for the prevention and treatment of COVID-19 infection, another systematic review, meta-analysis, trial sequential analysis to inform clinical guidelines. And if you go to the NIH website, you can do this at home. When I heard this, I said, I got to check this out. Go to nih.gov, or you put in your Google search box, NIH Table 2E, characteristics of antiviral agents that are approved. And you can just go up to approved, forget the under evaluation, for the treatment of COVID-19. And you're going to get this table. First on there is remdesivir. Remdesivir can only be given in the hospital. I won't spend a whole, well, maybe I will say one thing or two things about remdesivir. Only IV. Hospitals are getting paid more if they give remdesivir to their patients. And that's published data from CMS. And there's been this debate. I actually may have a slide on it now that I'm talking about it. I'll show you that in a minute. I'll save the rest for later. So this is page 1, remdesivir for hospitalized patients. Page 2. I couldn't blow it up anymore. I would miss some of the stuff here. But can you read it there? It says ivermectin, number 2. Ivermectin is on the NIH website as an approved agent, an agent that can be used in the hospitalized patients for COVID-19. I will tell you, I did not know this, okay, until just a few weeks ago, that it is actually, permission has been granted for physicians. But do physicians know this? No. Why not? Because all we are told is remdesivir, remdesivir, remdesivir. An expensive medicine that can only be given IV when they have a cheap alternative that can be given orally. It's a tablet. Yeah. I'll just mention in passing, I found a place where you can get ivermectin by prescription now. But that'll be, I can leave some of the more controversial stuff for afterwards, okay? And number 3 on the list is another agent, nitazoxanide, which we'll talk about more at the end. Now, this is the slide I was referring to. World Health Organization on their website recommends, what does it say there? It says against the use of remdesivir for COVID-19 patients. So here we have the NIH saying that's the first drug, the CMS, Medicare, Medicaid saying if hospitals use remdesivir, they will get more money for the care of that patient. Yet the World Health Organization is saying, no, we don't recommend the use of remdesivir. Because yes, initially it seemed like it was going to be a shorter length of duration, but there's been a whole lot of controversy and the literature's been very mixed on remdesivir. Then another study saying, no, we shouldn't be using it, period. So the World Health Organization has gone with that, saying, no, for right now, worldwide, we don't recommend it, despite what the US is doing. Fluvoxamine, you guys have been watching the news recently, might have heard. Any of you heard about this drug on the news? No? Well, that's fascinating. Why not? That's a good choice, okay? But occasionally the news will have something interesting. This did a little splash, and you haven't heard about it. If I were in the news agency and want to help people, I would be publishing and announcing this and printing this not one time, but several times, because this is pretty much hot off the press. Effective early treatment with fluvoxamine on risk of emergency care and hospitalization among patients with COVID-19. The Together randomized platform clinical trial. So an old drug, fluvoxamine, new hope for COVID-19. Fluvoxamine is, all of you guys have heard of Prozac, right? Antidepressant. It's in that kind of family of antidepressants. Not used very much. In fact, I've never prescribed it as an antidepressant, but it's been out there and around. And basically, here's what the findings of the study. The proportion of patients observed in a COVID-19 emergency setting, so they come into the emergency room for more than 6 hours or transferred to a tertiary hospital due to COVID-19 was lower for the fluvoxamine group compared with placebo, 11% versus 16%. Notice they'll do the analysis in 2 different ways. The intention to treat analysis is saying that If you were in this group and we randomized you to take fluvoxamine, but you took it for just 1 day or 2 days, and then you quit taking it, we're still going to analyze your data as an intention to treat, even though you didn't finish the course. You started it, that's where you were supposed to be, but you didn't finish that course, okay, of treatment. So that's the intention to treat analysis. And in that group, there were 17 deaths in the fluvoxamine group, 25 deaths in the placebo group. Now, they look at the data another way, which is the per protocol population, which means you were supposed to get fluvoxamine, and you took it, and you completed the course. You did what you were supposed to do versus placebo, okay? And in that second group, there was 1 death in the fluvoxamine group, 12 in the placebo. This is outpatient treatment, easy to do, inexpensive. Why is this not hitting the news, even though you don't listen to the news, Mr. Bird? Yeah. I mean, well, it's a prescription item, so you'll need to get a doctor to prescribe it. I will not speculate, but it so happens that in medicine, money has a lot to do with how we do things. Pharmaceuticals too. Don't get me talking on that. Budesonide, another agent. Inhaled budesonide in the treatment of early COVID-19, a phase 2 open label randomized controlled trial. It was published in the Lancet, one of the major journals in medicine, okay, this year. And actually, if I'm not, it's published online April, and then in the paper print, it was, I want to say, August. So this is a fairly recent publication. And here's their conclusion. Early administration of inhaled budesonide reduced the likelihood of needing urgent medical care and reduced time to recovery after early COVID-19. Is there something that you can do to treat yourself or a family member if he is COVID positive? The answer is yes. There's lots of things that we are seeing here that for some reason is not getting spread. Inhaled budesonide reduces the risk of emergency department evaluation or hospitalization in early COVID-19. American Family Physician, published August 2021. And American College of Cardiology have an article, Inhaled Budesonide for COVID-19 Patients at High Risk, a September 10 publication in the Lancet. And here's what they say. Here's the little summary. Inhaled budesonide reduced time to recovery with a high probability of, I can't see the end of the slide there, also reducing COVID-19 related hospital admissions or deaths by an absolute difference of 2% for people at higher risk of hospital admission and death in COVID-19 in the community. So they say, based on these data, inhaled budesonide may be considered for patients for COVID-19 who are at high risk for complications in the community. So we've got another option here to add to our armamentarium. What about colchicine? Colchicine is a drug that we use primarily in gout. It's a great anti-inflammatory. We are using gout now actually in acute heart attack settings where there's a lot of inflammation going on in the heart, and colchicine will help here with that. And beneficial effects of colchicine for moderate to severe COVID-19, another randomized, double-blind, placebo-controlled trial. Some of the things that you will hear folks saying, we need randomized trials to know what to do. Well, here we are having randomized trials as to what to do. And I just clipped here a portion out of the article itself. What does this study add? This work presents data of a randomized controlled trial of colchicine for hospitalized patients with COVID-19. The drug reduced the length of need for supplemental oxygen and the length of hospitalization. Safe, well tolerated. The most common adverse effect was diarrhea, which we've known all along. That's what happens when we give too much colchicine to a gout patient. They get diarrhea. Colchicine for community treated patients. That means you're not in the hospital. And another randomized trial. And I had this highlighted, meaning that it was published also in the Lancet this year, just a few weeks ago. Among patients with confirmed COVID-19, colchicine led to a lower rate of composite death or hospital admission than placebo. Well, I do say replication in other studies is recommended. That will often be said with these randomized trials, said, hey, we'd like to see more studies confirm what we found. Okay, so you test positive. You could also get colchicine, and your chances of going to that phase 3 where you need to go to the hospital because you're so short of breath or so lousy or so sick are dramatically decreased if you take colchicine. Aspirin use, and this was GW at George Washington putting this in their newsletter. I was having a hard time finding the study as clearly stated as they have it here. Aspirin use may decrease ventilation, ICU admission, and death in COVID-19 patients. Found aspirin may have lung protective effects, reduce in-hospital mortality in hospitalized COVID-19 patients. And actually, here's that study. I'm sorry, I did find it. Aspirin use decreased mechanical ventilation, ICU, in hospital mortality. And that was published in Anesthesia, Analgesia. That was back in March of this year. Then we have this other agent that I mentioned, this nitazoxanide, a drug that I've never seen, but is on that FDA, not FDA, on the NIH table 2E, okay? Nitazoxanide superiority to placebo to treat moderate COVID-19, a pilot proof of concept randomized double-blind clinical trial. And this was July 2021. It's an online journal that you can find there in eClinical Medicine. And I basically say nitazoxanide was superior to placebo when considering that SSD, which is this scale for disease severity, very significantly. The mean time for hospital discharge, 6.6 versus 14 days. That is way better than remdesivir. Okay, that has better, a greater shortening of hospital stay than remdesivir does. Okay, and a negative PCR. So their test is now negative at day 21 at a very significant rate. So then I came across this one. And you noticed I have not talked about hydroxychloroquine, except in this slide. Hydroxychloroquine, lots of controversy. back and forth. I have not made up my mind entirely yet on hydroxychloroquine. I'll just mention a couple of things on it, not on slides. Some of the US decisions to not use hydroxychloroquine came from a study that was published in The Lancet, saying that, quotes, it did not work. And that article was subsequently retracted. That was, and they put it there, retracted. And there's a whole story behind it. But because that got published in The Lancet as a drug that did not work for COVID, that's all the news it got. And nobody heard that it had been retracted. Now, again, COVID-19 has been very highly politicized. And I just have to ask questions. I've shown you a bunch of other Lancet articles. Why are we not making decisions based off those Lancet articles? So what they showed here, early COVID-19 with azithromycin, and they add either nitazoxanide, ivermectin, or hydroxychloroquine in outpatient settings. You are at home, you tested positive, we can give you something. You're not feeling good, you're not sick enough to go to the hospital. I can give you something now that has a good chance to help you. And they say it significantly improved COVID-19 outcomes compared to known outcomes in untreated patients. And this is a study done in Brazil, and it's a prospective observational study. It's got some interesting things as to how they came up with the control groups, and I'm not a statistician, so it was honestly a little hard for me to figure out how they came up with the control groups, but they had two different control groups compared to the treated individuals, and they used, again, nitazoxanide, ivermectin, or hydroxychloroquine. They say demonstrated unexpected improvements in COVID-19 outcomes when compared to untreated patients. The active group, AG, compared to the control group 1, CG1, or control group number 2, CG2. So you compare these. The active group showed a reduction of 31 to 36% in viral shedding, 70 to 85% reduction in disease duration, and that says 100% in respiratory complications, hospitalization, mechanical ventilation, death, post-COVID manifestations. That is, all of their patients that were on this treatment program of azithromycin, and it did not have to be all three. It was one of the three or some combination thereof. None of those patients ended up in the hospital. Now, they go on to say, benefits from combination of early COVID-19 detection and early pharmacologic approaches were consistent and overwhelming when compared to untreated groups. So I found this fascinating because I had put my slides together in this concept of, I don't think that it is a one drug, does it work? But let me give you a whole host of things and see what happens, as I think this is a multi-pronged approach. And last night, okay, I'll just call it God's providence, this article came up while I was doing research and said, wow, that kind of confirms what I've been thinking all along, okay? So, do we have options. Yes, many options. And I will propose to you folks, my colleagues, do not hear this. Why? Because we get fed remdesivir and vaccinate. Remdesivir and vaccinate. Oh, there's one other. Here I'm talking. There's one other agent that I have in here, but I forgot to put slides on, okay, which is the infusion antibodies. You guys heard about those? Interesting. I printed the articles and forgot to put them on the slides, but let me just make a comment here on the infusion antibodies. So most of the doctors in this country have not heard about the infusion antibodies either, but they are beneficial. They are helpful in the outpatient setting. These are basically, again, antibodies designed, if you may, here to identify and neutralize the virus. Interesting. Tennessee is one of the states that has been using, let me back up. Tennessee is one of the states that there's vaccine hesitancy. You guys have heard that, right? And I have not touched vaccine, and I won't talk about vaccine. It's too much of a political issue, and I want to keep my medical license. I'll leave it at that. So Tennessee is one of those states where there's a lot of vaccine hesitancy, yet it is one of the states that is using a lot more of the antibody infusions than the rest of the United States. To the point that recently I got some email communication saying, you know, we need to distribute this equitably. Some states are taking too much use, they're using too much of this antibody infusion stuff. And I say, wait a minute. If the stuff works, it's safe, why not use it? Just produce more. I mean, you're producing lots of vaccine, right? So there are different, there are 3 different combinations of antibodies. Monoclonal antibodies are monoclonal antibodies are designed to target a particular aspect of a virus. In this case, we use monoclonal antibodies here for patients with psoriasis. It's an infusion, or this one is a 1-hour infusion given typically in the emergency room. It requires a note. You go in. I actually have had people. I've told people just go to the emergency room saying that you need the infusion. In the VA setting, we say we recommend this. We write a note. The patient goes to the ER, and they get the infusion in the emergency room, 1-hour duration, then they go home. It is zero charge to the patient, just like COVID testing and just like the COVID vaccine. It is zero charge to the patient. Okay. You had a question? Correct. So COVID testing should be free. Some places are charging. So my son had a $35 copay visit for his urgent care visit, but everything else was covered by insurance because that's part of the legislation. Anything COVID related is covered essentially. That's why you don't pay, if you get the vaccine, you don't pay for it because that's part of legislation, okay? Part of the billions that have been put into it. What's that? They should, yes, they should take your insurance card. We've had we've had enough exposure, and my kids are in college. They've had to show negative tests when they've had the sniffles. So they've run in there several times to show they're COVID negative, but it's been all free. The antibody infusion should be all covered and zero. Mm-hmm. The antibody is an infusion, should not be a shot. Okay. And so it needs to be an infusion. It should not be given rapidly. Okay. So back to your other question, what are antibodies? So we use monoclonal antibodies synthesized in the lab. I showed you at the beginning that we have antibodies both in the natural immunity side and in the adaptive immunity side. So when you get the flu shot, when you get the tetanus shot, when you get the shingles shot, what you are doing is presenting to the immune system either a part of the virus or the whole virus. You know, in the flu case, it's or some of these vaccines, it's the actual virus, but it's been smashed, weakened, so it can't give you infection. But the body recognizes that, and it creates antibodies to different parts of that virus or bacteria. Okay, they have in the laboratory been able to now synthesize these antibodies to specific parts of the virus in this case, mass produce it, and now give it to you in an infusion so that these antibodies are now circulating and able to attach onto that virus and neutralize it. Okay. So so where Tennessee, I already told you here, Tennessee was using a lot of it because there's a lot of vaccine hesitancy here and more use of it. Appropriately so, I say. But FDA wasn't quite liking it and saying, hey, you know, Tennessee needs to use less and let it be used in other places. Well, let's just produce more and tell the whole world that this stuff works. Okay. So right now, the recommendations are over 65. And if you have severe, or if you're under 65, if you have comorbidities, if you got lung disease, or you're really sick. Okay. But over 65, you tested positive, you've got symptoms, you're not feeling all that great. You have to understand, COVID is a full spectrum, okay, where tons of people, at least 10 times, again, from this original slide I show you, at least 10 times the number of positive individuals are individuals who've been exposed and they're out there around feeling fine, asymptomatic, no issues, okay? I don't want to treat those individuals. So some of them get tested because a friend of theirs got COVID and they had a little runny nose and said, hey, maybe I should get tested. Or, as happened in my setting, colleague gets positive, I need to be tested, and I'm negative, but if I would have turned positive, I'm not having a whole lot of symptoms. Okay, so I don't want to be treating asymptomatic individuals. You don't want to get this unless you're starting to really feel kind of crummy and saying, you know, something should be done here. Okay, so again, you have a full armamentarium now of other ideas, and what I want to suggest to you is that you become ambassadors. You share this with as many health professionals as you know, okay? And tell them, and you can use my name, that's perfectly okay, all right? The data is there, available to anybody and everybody. I did not make up these articles or fake news them, okay? They are there, available for anybody to review. Okay, I would propose that we encourage as much people, personnel, hospital personnel, medical people, to look it up and look at options. Don't rely on what the CDC tells you. I showed you at the beginning what the CDC says. What are you supposed to do according to the CDC? Stay home, wash your hands, cover your nose, clean surfaces, and wait till something happens. Why wait when we have all these options that we can be doing? Okay. I'm not saying don't trust our government. I never said that. Okay. I never said that. Okay. There's lots of good things about this U.S. government. I'm glad to live in the United States and not in other places in this world. Okay. But this is science that is out there, available, and we should be looking for it and using it. I'll finish with these two slides. Because the bottom line is, who has control over your life and my life? But the good Lord, okay? And how long I live does not depend as to what supplements, what medicines I take, and how much I exercise, and how many greens I have, or any such thing. As good as they may be, okay? How long I live here is plainly determined by when God wants to call me home, okay? So most importantly is spend time in the Word, getting to know our God. And we finish with this text. Proverbs 1:33 says, "But whoever listens to me will live securely and will be at ease from the dread of evil." Isn't that a good promise? I'll take questions for a few minutes.
Okay, well, in general, you start off by saying, see, what can we do? And you gave the quote about the fact that there are 10 times as many people that probably have been exposed and maybe have the virus but don't realize they had no symptoms. And what are we going to do? So if you don't have any symptoms, and you're not, unless someone forces you to take a test, you don't go get tested, you're operating under the theory that you're fine, you're healthy. And hopefully we'll follow all these things you shared with us tonight about strengthening our immune system. So that, I guess my question is simply, there's a lot of people that may have had it, and now they got, if that's the case, they never had symptoms themselves, but aren't they building up immunities within their body because they've had the virus itself?
The answer is yes. So I will give you a Biology 101 answer that, again, does not quite fit what the CDC is saying, but it's Biology 101. If I have had exposure to it, I should be able to measure antibodies. If I had enough exposure to it. Again, I can't explain what happened when, except to say that my innate immune system was so revved up because I was just on this like a dog initially. I can't explain why my antibody test was negative in January and February when I tested it, when I was exposed significantly with my son. Okay. And why in the world do I then get sick in August? Because I relaxed. I'll be honest with you. There was long periods of time that I wasn't taking the supplements. I was still doing my contrast showers, but I was really relaxed as far as the supplements. And it's been high stress time. I did not talk about stress but stress definitely weakens the immune system. And you got stress, you got some days where you're not sleeping appropriately, and you get enough stuff not quite in sync. And I'm exposed to this stuff all the time. Okay. I may be crazy, but I actually was wanting to get it because there's nothing better than natural immunity. Okay. So I can look back now and say, I'm glad I got it. I mean, it was kind of lousy 2 weeks, but hey, I've got fantastic immunity. And Biology 101 says, now I've got memory cells. My antibody titers may start decreasing unless I get exposed again. And boom, those kick in within a few days, and I get antibody titers up again very quickly. Okay. So maybe I'll say, I have to be careful if this is recorded. I've actually intentionally, we have once a week I need to cover the what we call acute respiratory clinic. So I actually take off my mask and talk to them and say, if you've got the bug, bring it on. I mean, I want to keep my immune system challenged and developing natural antibodies. Maybe Castro's a little crazy. That's okay. But I go back to Biology 101. Any other questions? Yes.
So if you've had, like you had the Delta variant, and so what happens if you're exposed to the Alpha, the original?
So I'm quite certain I had the Delta just because that's what was so prevalent, and the type of symptoms I had. And let me again say, so I had Delta, highly contagious. Neither Lorena nor Josh, who were at home, got sick. Okay. Did I stay in a confined room? I did for day 1 and day 2 because Lorena said, quit moving around all over the house. So I says, okay. So, but that only lasted a day and a half, and I was going crazy, so I throughout the whole house. Why in the world, if it's that contagious, Lorena and Josh did not get sick? There's stuff I can't explain. Okay. Natural immunity is, as I mentioned, the body, if you get one of these bacteria that's live attenuated, okay, the body will not create just one antibody to one part of it. When you're getting the vaccine, all you're getting is one piece of the spike protein, okay? When I get natural immunity against any virus or bacteria, the body will create antibodies to multiple parts of the bacteria or the virus. So these variants are stuff that are where there's a change typically in the spike protein of some sort, allowing it to be a little bit more contagious or easier to enter the cell or something of that sort. But other parts of the virus continue to be pretty much the same, enough so that they're still in the family of the coronaviruses. And the body will recognize, hey, you look awfully familiar. I know I've seen you. You're not exactly the same, but you're close enough that I'm going to take care of you. Okay. So you had other questions?
Now, I had read and heard that using hydrogen peroxide in a nebulizer would help. Have you heard that?
Yes, I have. I have not researched it, so I don't have scientific data here to share with you.
And then a question about vitamin D toxicity. Is it possible to have too much vitamin D?
At the doses of 2,000 to 5,000, extremely difficult to get toxicity with it. You can do this for a couple of years without any concern. Yeah. Do you have more?
And then when you were giving the doses for the supplements, is that for prevention or treatment?
Good point. So vitamin D, pretty much for prevention and treatment, is pretty much the same. What I do for folks who come to me and have not been on supplement of any sort, and they come to me positive, symptomatic, I bolus them with vitamin D, 50,000 units for 3 days, and then every day thereafter 5,000 units. Okay. Vitamin C for prevention, it's 1,000 milligrams every day for prevention. For treatment, 1,000 milligrams 3 times a day. Zinc, 30 to 50 milligrams every day for prevention. When I get a patient that's positive or discharged from the hospital, I pretty much always tell them 100 milligrams of zinc a day for 1 month. Then you decrease it to 50 milligrams a day. For how long? I honestly am kind of playing it by ear. Again, these guys are developing natural immunity. Some of this is uncharted territory. I'm learning here with other docs that are learning as they are treating this. So those are the 3 main supplements. Ivermectin, you saw some of the studies there. It's typically 3 to 5 day duration treatment. I'll tell you what I did. I did day 1, day 2, day 3 in a row. I waited, saying, hey, I'm starting to feel better. I skipped a day, did the 4th dose, skipped a day or 2, and did the 5th dose. You will read in folks that are using ivermectin, and there's worldwide experience with this. Typically, it's daily for 5 days. I honestly, in my book, the less pills I have to take, the less medicines I have to take, the happier I am. So I was testing myself 3 days. I'm not back on my feet yet. Let me take another 4th dose, see how I do. And I wasn't quite at my feet the way I wanted to, so I took the 5th dose.
So about the ivermectin, this is interesting because when we were going to travel to Maine and we wanted some ivermectin, contacted our doctor, and he said he would not prescribe it because it was not approved, FDA approved. And so I said, okay. So then I read, it was about a month, maybe a month ago, that now it is FDA approved. So I don't know how long it has been FDA approved. I don't think it was back in August, but it is now. So I just thought that was interesting.
Yes, and it's making its way in publications, but nobody's talking much about it and letting us know.
Just a question about the ivermectin. Can that be taken preventively, prophylactically, as opposed to taking it after you've already been exposed?
Yes, and I didn't. So the data there is not totally peer reviewed yet. There are articles that are being reviewed for its scientific scrutiny stuff, showing that prophylaxis done on a weekly basis, a particular dose once a week, as being helpful. Yes. I'm of the philosophy, the less pills, the less medicines I take, the happier I am. So I chose not to prophylax. I prefer to get exposed. Again, this crazy Castro.
And speaking about that, the ivermectin, now some people are buying it from the co-op that's used for horses, and some people are getting it prescribed. Is there a difference between the two?
Okay. So it is the same drug, though they will tell you it is for horses or other animals and not for human use, but it is still the same drug. At Loma Linda, my secretary's husband was a vet, and he would routinely intermix human medicine versus vet medicine, whichever one was cheaper. Okay. Whichever one you could get at less price, because it's basically the same compound. Now, the FDA won't like me saying that, and yes, it is not. It is sold here for animal use and not human use. You can get ivermectin online from places, and once we're done, actually, I can tell you places where you can search that out if you want it. Yes.
So with some of the things that you're mentioning that isn't well known by most physicians, or for whatever reason they don't do the things that you've recommended or seen in the literature, if one of us or someone that we know becomes hospitalized with COVID, and we would like for ourselves or them to have these treatments, is there a way to influence your doctor to give you these things, since they are reviewed and scientifically based?
So my thought is that yes, just as much as in the non-VA setting, okay, and the private sector, you can fire your doctor saying, I don't want you taking care of me anymore. I want somebody else to come in and take care of me. The hospital is to find you another doctor who will take care of you. In the outpatient setting, you don't like going to Castro's office, you can go down the street and see Dr. Jones, Dr. Smith, Dr. whatever. So you can choose your doctor. When you're hospitalized, you have some say. It's part of patient autonomy at saying both what treatment you get. They cannot impose treatments that you do not approve of, particularly if it's invasive stuff. Okay. I mean, we are accustomed to say, well, a doctor said so, so yes, yes. That has changed over the last 15 years. We're here in East Tennessee, where I still see a lot more of that, okay, the doctor said so. And being a doctor, that kind of feels good. You have this power, all and so on. I will tell you, it's great to have empowered patients who challenge you, who ask you questions. California, they're all empowered. They don't listen to the doctor anyways. But yes, you have the power to say, hey, did you know there's nothing wrong with you saying, I would encourage you to follow what the guidelines are saying. NIH Table 2E says these are medicines that can be used. No, I don't want remdesivir. I want ivermectin for my loved one who's in the hospital. Yes, you can do that. And it may require a little pushing and twisting arms, but then it's the hospital administration's job to take care of that. Yeah. And we'll do one last question, and we'll wrap up.
What if you're in the hospital, or your loved one's in the hospital, and you cannot find a doctor that will do what you want done?
So there are times when you need to make suboptimal choices. And it all depends as to how sick your loved one is. Can the patient be transferred to another hospital? Something for you to think about. We would do it all the time there when I was at Loma Linda. They'd be hospitalized at a hospital that will remain nameless. And the rule was, if you ended up in the hospital there and you were sick, please ask for a transfer. It doesn't matter how sick you were. And whenever we were on call, they got a call from that hospital, and we say, bring them in. I don't care what the history is, just bring them in. Okay. So yes, you can ask for transfer to a different hospital, and there's options around here. Not really close, but it may require ambulance transfer and so on, but yes, you can do that. Oh.
Yeah, and so they're helpless. The person is really helpless if they won't allow any family members to come in.
Yeah. So things are easing up a little bit. There's a little bit more penetrance into getting into the hospital as a family member. Yeah, a lot of it is kind of uncharted territory. We're still kind of figuring out our way through. So, again, are there things that we can do here to prevent COVID? Yes. Are there things that we can do if you do end up being positive? Yes. Okay. This is not a hopeless situation, as I've had so many people come to me saying, my doctor just told me go home and hope for the best and write your will and be ready. Okay. Because there's nothing that we can do. There's a lot that we can do. Okay. So I want to leave you with hope, and most importantly, with the promise, again, whoever listens to me will live securely and will be at ease from the dread of evil. Let's bow our heads for prayer. Heavenly Father, I thank you that we can put our trust in you, not on all the inventions, even good things of natural lifestyle things that we can do, but to know that our life entirely depends on you. And so we put our trust in you again, and asking that your will be done in our lives, in our communities, in our families. And take us home safely, we ask in Jesus' name. Amen.